Good morning. Thank you very much for the invitation. I agree with the last speaker. This is a very exciting time for MRI, for cardiac MR particularly, and the lectures today I think exemplify that. What I'm going to try to set up here, I think the task for me is what if the issue is not ischemic? How do these patients come up? And in my view, they come up basically in three different formats that in the cine you can pretty much allocate to one of these three and then start your thinking from that perspective. So instead of going through a collection of here's the best, I'm going to just try to set up that thinking. We are going to start with half of the conversation will be on dilated cardiomyopathies and the other half on hypertrophic. But at the end, I'm going to talk about what if the heart doesn't look very abnormal? What kind of things should you think about? But the most frequent situation is if the heart is dilated and if you could pass the next slide. If the heart is dilated, and I'm just going to make sure that I can pass the other ones. If the heart is dilated, and the story is that it's recent, in other words, it appears to the person following this patient that the problem is in the last few days or in the last 24 hours, then the choices become either ischemic, and if it is ischemic, you're going to see a very large myocardial infarction. And it doesn't look like chronic, so the wall is thick, and there may be microvascular obstruction. So the ejection fraction is going to be down, but you're going to see a clearly ischemic situation. If you don't see any of that, then think stress cardiomyopathy, cardiomyopathy generated by emotion, by somebody who had a very strong emotion or had a very large discharge of norepinephrine. And those come under the name of Takotsubo cardiomyopathy. Takotsubo because of the shape of this. Takotsubo is like a trap for squid that used in Japan, and the shape is a little bit like that. If you don't see any delayed enhancement, a lot of dysfunction, recent onset, think stress cardiomyopathy. And in ischemia, you may have no delayed enhancement, but if that happens because the artery was opened very fast, you will know that. So if the following physician, the attending physician, doesn't tell you this story, this is the algorithm. If the problem is chronic, is generally a very large infarct in the past, like in this person here who had a very large anterior MI and with a thrombus, or several MIs. And that story should be clear also because this person should have had previous admissions, should be known for having MIs, and can you pass the next one? So if the problem is going to be a dilated cardiomyopathy that appeared and it appears to those who are following the patient that the problem is chronic. The issue is going to be, of course, to define the ejection fraction and the structure and function of the heart, but then the question is going to be the presence of GAD. If there is delayed enhancement, there is much worse prognosis than if there is no delayed enhancement. This situation is actually very uncommon. So the question question of no delayed enhancement, but it happens. And the prognosis is much better. So a lot of dilatation, a lot of dysfunction, no delayed enhancement, better prognosis. What kind of pattern are you going to expect? Well, it's really hard to tell you that there is a typical pattern. You know, it can be a pattern that looks ischemic like this one, but it's generally mid-wall or it's generally subepicardium. So the pattern is pretty different than the ischemic one most of the time. Sometimes it's going to be blotchy like this. And the patient will have, therefore, a lot of dysfunction, GAD or scar on GAD, and that's going to be the typical patient with a dilated cardiomyopathy. Now, sometimes the presentation is much more acute, and in those, my experience is that generally these are going to be younger patients, and sometimes you're going to be involved on somebody who actually has bouts of this, of what people think are acute myocarditis because they have a strange EKG, and they haven't shown up yet with delayed enhancement. If they, and sometimes in the first presentation of this, they'll have delayed enhancement, like in this patient, a 25-year-old person who had delayed enhancement right in the beginning. Sometimes they will present with arrhythmias, with VT outside, and being brought to the hospital. They may have a troponin that is a little bit elevated, but will have gadolinium enhancement that is generally subepicardium like this. So this is a typical presentation of myocarditis. You can do T2 imaging in these patients. It's very helpful, but the diagnosis comes from delayed enhancement in the subepicardium or in very in a distribution that is not typical for in relation to the troponin rise. The rise in troponin is much lower than you would see for ischemic myocardial infarction that would lead to such damage. And besides, the damage, as I said, is generally subepicardium. Somehow, you're going to be seeing some of these patients coming from high-level sports. So my impression is high-level sports somehow elicit on somebody who has myocarditis, arrhythmia, and sometimes cardiac arrest. So we've seen several cases of patients who had arrests during games, and that's the pattern that you're going to see on MR if they survive. Sometimes it's during a routine exam for the team. So and the big questions come if these patients should continue to play contact sports or not. One pattern that is particularly worrisome is a mid-wall pattern, and the first report on this came from Saman Azarian, but and it relates to the fact that if the wall is deep, if the scar is deep in the myocardium, there is a lot of chances for arrhythmia, and the group in England has had a lot of the group of Dr. Asumul, Sanjay Prasad, and Penel had a lot of experience with this. In 2006, they published a very nice study with a follow-up of these patients. If you could pass the next slide, please. Thank you. More recently, in the next, somehow I'm not being able to advance those with a click. Could you give me the next slide? Yes. More recent, they updated this database and follow-up of these patients, showing that if you have, if the pattern of delayed enhancement is mid-wall like this, it's particularly troublesome, and the prognosis, the chances of sudden cardiac death and heart failure are much greater. Another condition, if you're practicing in South America, then a lot of times when you see a lot of fibrosis, this is being caused by Chagas heart disease. There has been actually one case naturally occurring in the U.S. a couple of years ago, and for those who see a lot of patients who come from Latin America, that's a common occurrence. And in this cardiomyopathy follows a lot the pattern that we see in other cardiomyopathies. But if you see a lot of fibrosis, the chances of sudden death and the chance of heart failure increases significantly with Chagas heart disease. And my impression there is that in Chagas there is a combination of scar, of fibrosis with inflammation. But the condition where that is particularly true, could you advance the slide, please, is in sarcoidosis. And sarcoidosis is not that rare. Every time that I'm in the inpatient service at Hopkins, and I do that for a couple weeks at a time, I see a patient with sarcoidosis. So it can't be, of course there is referral bias, but it can't be that rare. The issue there is that fibrosis with inflammation is the right trigger for arrhythmias. These patients generally present with a dilated heart. Sometimes actually the heart dimension is actually not that abnormal, but if you see these blotch areas of delayed enhancement in a patient with arrhythmias, even if it's just PVC, but a significant load of PVCs, that's bad news. Now the good news is that these patients, the patients who present with a lot of inflammation, they respond to steroids. And if the lesions go from being, blotchy like this to being very well defined like this, sometimes the arrhythmia subsides and the patient goes into a quiet phase, and you don't really need to have a defibrillator implanted or some other drastic measure to control arrhythmias. But it's not infrequent that even with steroid, patients continue to have reentrant ventricular tachycardia, and then a defibrillator is needed. If you could advance the slide for me. Oh. I'm sorry. We're just so I've had patients with significant PVC load who had presented quite a challenge. This is back to the issue of sarcoidosis. So how does sarcoidosis presents? Thank you. If you could go back one, I'm not going to even try to do it because I'm afraid now. If you go back another one. Actually, yeah, we are going to need to go back quite a bit. Please, more. Very good. Very good. Here. Perfect. Thank you. If you could advance the next one. So I was finishing telling you that in patients with sarcoidosis, many times the issue of how much PVC load they have, and it becomes quite crucial. We can talk more about that. The classic cardiomyopathy that has been addressed by MR for decades is arrhythmogenic ventricular dysplasia. And arrhythmogenic ventricular dysplasia generally is not opposite to sarcoidosis, quite rare. So what you're going to see the most is people with question, ARVD, and in the end, it's not going to be ARVD. But how should you think of ARVD? If the right side of the heart is very dilated and dysfunctional, think of ARVD. Most of the time, in this situation, in the absence of fat infiltration of the heart, when you do fat suppression, or in the absence of delayed enhancement of the RV, most of the time, it's not going to be ARVD. And there will be a lot of, you're going to see a lot of rule-outs ARVD. But those are very specific changes for ARVD, and in combination with many other factors, you will make or exclude the diagnosis of ARVD. Next slide, please. Delayed enhancement is, again, powerful in ARVD because it's very specific, it's not very sensitive, and as I said, you will need other diagnosis or other sources of diagnosis. Next slide, please. Back to, we talked about the dilated paradigm. Let's talk about the hypertrophic paradigm. This has been really a very important experience for cardiac MR because in these patients, cardiac MR is fundamental. So if I can have the next slide, please. This is the most typical presentation of hypertrophic cardiomyopathy with a septum that is much greater, much thicker than the posterior wall. So if you're in front of a patient that looks like this, you know the problem is hypertrophic cardiomyopathy. Now it could be hypertrophic all walls. You know, it could be homogeneous hypertrophy. It doesn't have to be asymmetric. But I'm presenting to you the most common presentation of this. And the presence of delayed enhancement in these patients, it does portend a bad prognosis. Next slide, please. It does portend a risk of heart failure, risk of sudden death. There have been this issue in September of JACC 2010 has 2 papers back-to-back that are very important in setting up the risk or demonstrating the risk of patients with scars and hypertrophic cardiomyopathy. And there are recent work by Martin Maron showing that actually the quantification of scar is directly related to prognosis. Now, this is not in the guidelines yet for placement, for example, of a defibrillator in patients with hypertrophic cardiomyopathy, but it's something that is clearly in those who take care of these patients figuring very prominently. You can use MRI to follow patients after ablation, after surgical myectomy. If you could advance the slide, please. I'd like to call your attention for apical hypertrophy. Why? Because it's very it's commonly missed by echocardiography. So it's very important that you are able to pick up hypertrophic cardiomyopathy of apical distribution because these patients are frequently missed by echo. Are we going to do MR in patients with pure hypertension? I think that in the future, yes. Right now, we don't. But this comes from a study that clearly demonstrates that in patients with hypertension, there is a very strong component of fibrosis. And if you're talking about hypertension of the left ventricle only created by aortic stenosis, actually the presence of fibrosis is related to prognosis, even after you replace the valve. And now that we can do this, in a way that is non-invasive with TAVR, this is going to be a problem that you're going to face more and more. So the presence of fibrosis is related to prognosis if you do it by histopathology, but if you do it by MR, there is the same distribution. And actually, I think we underutilize MR in patients with aortic stenosis. How do we image it? We generally do pre-contrast T1. You're going to hear all about T1 later on in this section. We do a 4-chamber view and then inject GAD. And then we continue to acquire the CINI, and we do the 4-chamber view just because of timing, because we still use breath hold most of the time for the routine imaging, and by 12 minutes we like to acquire more T1 data, and at that point we look at the LGE and the PSIR images, and you're going to hear the details of and the physics of that by Dr. Kelman, who actually developed PSIR. And then we generally obtain post-contrast at about 20-25 minutes. For patients with acute myocarditis, you can use T1 imaging, fat suppression for ARVD. There are several options, but I'm going to move to finish with a patient that doesn't look like that has an abnormal heart. And I know that these I can't pass, and I'm going to ask you to advance the slide for me. Thank you. In most of these patients, the issue is going to be actually concentric remodeling. So in most of the patients who don't look dilated or hypertrophied, actually what the final diagnosis is going to be an elderly person, somebody with a small heart that has what we call heart failure with preserved ejection fraction, or HFpEF. And this person keeps coming back to the hospital with a ventricle that looks like that, is hypertrophied, but the LV mass is, in absolute terms, is really not increased. And why does this happen? Well, this is data from the MESA study now. It shows that as we get old, our heart becomes smaller. Our heart becomes smaller in men, in blue, in women. And we imaged these patients, these participants 10 years later, and the hearts were even smaller. So there is a cohort effect, and there is a longitudinal prospective effect. If we relate to the mass, then the mass to volume ratio is very abnormal in these individuals, and we think that this could be at the heart of HFpEF, because the stroke volume becomes decreased, the ejection fraction is maintained, but it's mainly because the heart has shrunk, and most of these patients will behave like that, particularly those who have a history of radiation. If you have somebody who received a lot of radiation to treat cancer, they can develop a restrictive cardiomyopathy. In other words, they can develop this physiology very intensely and keep coming back to the hospital with what we call, again, HFpEF, heart failure with preserved ejection fraction. And Susan Chang, who is now at the Brigham, showed very clearly in MESA that if you develop this phenotype, if it's very exaggerated or you developed early in life, that the chances of event are very high. Therefore, concentric remodeling with dysfunction because of restrictive filling is a phenotype that is associated with events and is particularly bad early in life. But you can have the a heart that actually doesn't look very abnormal, although most patients with amyloidosis actually present with a heart that looks a little hypertrophied. And then the ECG doesn't look like hypertrophy at all. And that should be the flag to amyloidosis. And for you, doing the imaging, what's going to be the flag? The flag for amyloidosis should be something that you did everything right and the image is atrocious. That should be, you know, if you did everything right, the delayed enhancement, and the image looks like this, think amyloidosis, okay? Because a lot of times that's what it is. And it is infiltration of amyloid in the myocardium. And this condition actually presents with an abnormal T1, and it's probably, in my view, the condition that where T1 mapping is actually of clinical importance. And I'm basically finished. The other condition that can present with a normal heart, and you should have in mind, because it's infrequent, particularly here in the US, although in other places like Africa, endomyocardial fibrosis is not that infrequent. How do you get the hint? The ventricle is chopped off. And sometimes it's only the right ventricle, but sometimes when you have leukemia with a very high eosinophils, then you know, you can have either of these of the ventricles. Really, the apex is chopped off, so it's like this it's pericarditis of the endocardium. So in conclusion, MRI can assess LV function quite well, as you've seen this entire morning, and but it's the ability to quantify function and fibrosis that gives you the power, particularly useful in patients with suspected primary cardiomyopathy, plays also a very important role in sarcoidosis, in dilated cardiomyopathies, and arrhythmogenic ventricular dysplasia, and in hypertrophic disease, and it's also very important in patients with infiltrative myocardial disease. I would like to thank you and apologize for the slides, but I think we could discuss everything that was in the plan. Thank you.